Hi, I'm Alexei Danilov, a CLL physician at City of Hope, and we are coming to you virtually following up on the ASH annual meeting of 2022. And I'm joined by Dr. Furman, whom I invite to introduce himself.
Hi, I'm Rick Furman from Weill Cornell Medicine in New York, New York, and I'm director of the CLL Research Center here.
Dr. Furman, you presented some exciting research at the ASH 22 meeting from the abstract, which dealt with a phase 1/2 study of acalabrutinib monotherapy in patients with relapsed refractory CLL. So can you explain, please, what this study found?
So the study itself is actually a really long-term follow-up from the original phase 1 and 2 study, looking at patients who were previously untreated and previously treated with CLL who received acalabrutinib. The patients originally had received varying doses of acalabrutinib, and some did remain on their original dose, but most patients eventually ended up on 100 milligrams twice daily of the acalabrutinib. And the study really followed long-term outcomes, both in terms of the toxicities as well as the results in terms of responses and progression-free survival for these patients.
So were there any new safety signals or any new side effects that we haven't seen before?
No, the acalabrutinib was incredibly well tolerated, and we really, over the long term, didn't see any new safety signals with the longer follow-up. And this is, of course, is very important because when we look at agents like ibrutinib and zanubrutinib, we did identify later on that there were some unexpected adverse events. Most importantly was hypertension with ibrutinib. And we have not seen that with acalabrutinib.
Interesting. So, and there's been quite a lot of publicity with the Bruton recently about cardiac side effects, atrial fibrillation. You already mentioned hypertension, sudden death. Have there been any cases in this study?
So we really have not seen any concern in this study. I do think it's always very important to actually look in the phase 3 studies when you're trying to compare different drugs. You know, the best example, I think, is that when we looked at the phase 2 data with ibrutinib, you know, it never really occurred to us that hypertension was an issue until we started looking at the phase 3 data. And likewise with the atrial fibrillation. So when you look at acalabrutinib compared to ibrutinib, acalabrutinib does have a much lower rate of atrial fibrillation, the order of about 15 versus 9%. But I think certainly in the absence of a phase 3 trial, which we now do have in terms of the Elevate relapse refractory study, you know, really restricting any assessments, restricting any assessments of comparisons to really when we have the comparative data, because there's always differences in the patient populations. And in all fairness to ibrutinib, those patients were certainly much more difficult to treat, in part because patients who went on the original ibrutinib studies really tended to have gotten exposed to much more chemotherapy and have been much more heavily pretreated.
And so in terms of efficacy on this study, the duration of response, correct me if I'm wrong, was about 5 years. And this is certainly very impressive. What do you think of that?
Well, I think it is very impressive. The one caveat that's going to really remain true for the ibrutinib and acalabrutinib studies, and I think zanubrutinib is going to derive benefit from really being the last drug to market, is that, you know, these patients who have gotten prior chemotherapy really are much more difficult to treat. And it's in terms primarily seen with the incidence of 17p deletion and TP53 mutations. So when we look at the patients who really progress on BTK inhibitors, they really seem to be primarily those who have what could be think of as genomic instability and really have, which is probably most best measured by 17p deletion and TP53 mutation. And so the way that people end up with this in CLL most frequently is by receiving prior chemoimmunotherapy. So if you look at the treatment naive CLL population, we might have a 7 to 9% 17p deletion. And when you go to the even the Resonate or the 116 idelalisib study, the two pivotal studies for ibrutinib and idelalisib respectively, that percentage rises to 35 to 45%. So it really, I think, speaks to the fact that using chemoimmunotherapy first really makes, it does impact the long-term use of these drugs. And I think that's a very important issue when it comes to sequencing, that there's really no benefit to saving these drugs for later. But it also means that our patients who are going to be getting these treatments without ever having been exposed to prior chemoimmunotherapy will really do much better than the patients from these original studies.
Mm-hmm. Well, very interesting indeed, and I agree with you that all this data suggests that chemoimmunotherapy should really has very limited role, if any, in management of CLL now. So with recent approval of zanubrutinib, based in part on Alpine study results, where it was compared against the ibrutinib and showed improved efficacy and safety, how do you think that positions those two drugs, zanubrutinib and acalabrutinib, in the current landscape of treatment of CLL?
So I really think that, it's always nice to have more agents to use. I really have actually curtailed my ibrutinib use. And from my perspective, the cardiac arrhythmias, those both atrial and ventricular, really are sort of quite worrisome and really represent sort of the adverse events that we really can't recover from, or our patients can't recover from. So I do exclusively use zanubrutinib and acalabrutinib, and I do believe that they're both equally efficacious. Acalabrutinib had some issues related to needing to have an acid pH in the stomach, and with the new tablet formulation of acalabrutinib, those issues have been eliminated. So that was the one big impediment to acalabrutinib. Looking at zanubrutinib as compared to acalabrutinib, I therefore would say that both are equally efficacious. Acalabrutinib has issues, maybe bruising and headaches, and the zanubrutinib may be bruising and hypertension, but it's sort of nice that you can really choose which one is your preference. I find that, both are approved as BID drugs. Though zanubrutinib does have a once daily dosing, also approved. I am a little hesitant to use it some of the time, though, because the fear of the higher dose at one point in the day might lead to more adverse events than the twice daily dosing. But so far, we really haven't seen that borne out by any studies.
All right. Well, thank you very much, Dr. Furman, for this explanation of the data of acalabrutinib and CLL.
Thank you for having me.